Well, my name is Joe Suker. I'm the Vice President of the Arizona Trauma Association. Thank you all for being here. It's been a great program. How many people were at the Advanced Practice Provider Workshop yesterday? We have people still here for that? That was our first Advanced Practice Provider Workshop. It was a tremendous success. We had over 30, I think we had 35 participants, some from far away as New York. So we're going to continue to do that. That was a great time. But for now, I would like to introduce Dr. Andrew Bernard. Dr. Bernard comes from the University of Kentucky. He's the Down Chair of Trauma over there. He's also Chief of the Acute Care of Surgery. He spent his training, education, and fellowship and so on in the University of Kentucky. He must love Kentucky. And so he's going to talk to us about something that's a very important topic as we hit the opioid crisis. Dr. Bernard will talk to us about that. Thank you.
Thanks very much. It's really a treat to be here. You have fantastic weather here. This is great. Well, I bring you greetings from what I call inside the vortex here on the opioid crisis. I'm going to give you a view of the bad news. You know about this. I'm going to show you some data that'll make the bad news really vividly clear. But I'm going to leave you with some hope, I hope. I don't have any relevant disclosures. This is what we'll talk about. The harm of pain, briefly we'll talk about that. Mostly we'll talk about the harm of opiate pain medications and then some alternatives. The reality is that more than half of our patients, our ICU patients at least, experience and recall experiencing significant pain. So pain is part of our job. Fractures hurt, operations hurt, being suctioned when you're being mechanically ventilated, those things are uncomfortable. So pain is part of our reality. And pain is associated with negative effects. We can break those negative effects into several categories: physiologic, psychological, social, and economic. I just want to walk through a few of these. The physiologic effects of pain relate to stress primarily, the increased stress response, cardiovascular events. We all know little old men can't take days and days and days of stress. They get ischemic if you do that. Pulmonary complications are higher if we don't control rib fracture pain and the pain of incisions, for example. Pain can contribute to ventilator dysynchrony, diaphragmatic dysfunction. Hyperglycemia goes with stress. Stress ulcers, impaired wound healing, that goes with immunosuppression. There are psychological effects. We know that many of our patients, a quarter, maybe even a third of patients, have symptoms after their injury. They look normal to us and we say, wow, you look great when we see them in the office, but they're not great. They're having issues with anxiety, depression, even symptoms of PTSD that go months or years after the injury. And pain can exacerbate those symptoms. Delirium is a result of pain, depression, anxiety I mentioned. And there are social and economic factors. There used to be this checkbox on the patient experience survey, right, about how well do we control your pain. Thankfully, that one's gone away. And now it's how well did we talk to you about your pain? It's changed for a reason. But there was a while where we were driven by needing to control pain because the patient's experience was driving the economy. So these are all results of pain. But we're in a terrible situation now where opioid-related overdose is now the #1 cause of death. So it's more than crashes, it's more than knife and guns, and it's more than falls, as common as falls are now. Opioid-related overdose death is now the #1 injury-related cause of death in the United States, so here we are. So this figure shows methadone and oxycodone prescribing by country, and I just want you to see the disparity across the world and see that we're unique in the United States. Consumption of opiates is on the y-axis here. And across the x-axis, you see different countries: Australia, Brazil, Canada, China, some European countries, then Japan, Philippines, South Africa, and the United States on the far right. You can see that our methadone consumption is as high as anyone else. That's in the light bar. And our oxycodone consumption doubles every other country and is many hundredfold more than some countries, and this is per capita. So we're taking more oxycodone, we're taking more methadone than anybody else in the world. We're not biologically that different, right? This is just a prescribing behavior. As a result of more opioid consumption, we have more opioid, or at least drug-related deaths. This is not just opioids, this is all drug-related deaths. These are worldwide death rates from drug overdose. The USA is at the top, North America as a whole, Oceania, which is Micronesia and the Pacific Islands, Asia, Latin America, the world average. So look at the United States, 254 overdose deaths per million people, and that's 6 times the value for the entire world. So we're prescribing more, and we're overdosing and dying more. There's a relationship there. This isn't just about the person who dies from the overdose. We have to remember there's significant downstream effects that occur from every single overdose. We have this new phenomenon called opioid orphans. It's a big deal in Kentucky in particular, in Ohio and many of the other high opioid death states. These are families that are completely changed as a result of an opioid overdose. So it's not just about the individual who dies, it's the lasting effects. And here's another example of that. Neonatal abstinence syndrome. These are children who are born addicted. The rate is on the y-axis, and across the x-axis you see the year, and the rate of children born addicted to opioids has gone up and up and up every year. Kentucky, we lead the nation in a lot of not very good ways, and this is one of them. We're ahead of most everybody else in neonatal abstinence syndrome, and it's not just that you get the kid off, you get the kid better from the withdrawal, they get out of the NICU and now they're okay. These are standardized test scores in children who were born with neonatal abstinence syndrome. Now this is from New South Wales, so this isn't US data, but the relevance is still there. Mean composite test scores is on the y-axis here. And the x-axis is 3rd grade, 5th grade, 7th grade. So you see the New South Wales children as a whole and matched controls in those top 2 lines. And then you see the scores in the bottom line of children born with neonatal abstinence syndrome. So these children are scoring different on standardized tests in the 3rd, 5th, and 7th grade. So this is more of that long-term downstream effect of opioid abuse. So I want to walk you now through what happens when you prescribe some opiates. We're going to take 100 patients, like people here in the room, who don't take opiates all the time. You're at a meeting and you slip on a step or you step off the curb and you fracture your tibia, for example, and you go to one of the great trauma centers in this area that are part of this great trauma system, and you get care. And somebody prescribes you some hydrocodone or something on discharge. I want to walk you through 100 opiate-naive prescriptions and show you what happens to them. So we'll start at the top. The box on, I don't think I have a pointer here. I don't have a pointer, I don't think. Can you go back? No, I got it here. There we go. Let's take this box to your left, the immediate box bottom, right from the big box at the top, down left. You see appropriate use, no problems, took the entire prescription, didn't ask for a refill. That's 20. So 20% of the 100, they're going to take it, they're going to take them all, and they're not going to ask you for more. I know that sounds like a rare event, but that's at least 20%. Okay, 40% of the patients aren't going to take the whole prescription. 10, I'm on the out to the far left, 10 of those 40 are going to not take it all, they're going to dispose of it though. That's the success story. The trouble is the very bottom left, the 30 who didn't take it all, but they didn't dispose of it, and now they're floating. They're in a medicine cabinet, they're in somebody's bedside table, and these things are available to be used and abused and diverted. Those are dangerous. Now go off to the right side of the slide. Of those 100 now, we talked about 20 are going to take it all, 40 aren't going to take it all. There are 40 who are going to call you back for another refill. Of those 40 who call for a refill and you give it to them, 28 out of the 40 are going to take the refill, or 2 or 3. Ultimately, though, they're going to be done with them. They're not going to end up with a problem. It's the 12 of that 40 that end up in really big trouble. So 12 of the 40 or 12 of the 100, they're going to ask you for a refill. Here's what's going to happen. Straight down the middle, you see 10 of those people are going to misuse, become dependent, or become addicted. That's 10%. That's a lot. Now, that includes misuse, which would be misbehavior, not telling you the truth, all that stuff. But one of those people is going to become a heroin user, 1 in 100. One of the people is going to divert. They're basically going to go into business. And one of those patients is going to be dead. So if you think about the things that we do, hemorrhage control, fracture management, mechanical ventilation, all these things we do that save lives and salvage patients from injury and the risk of those things, here's a pretty risky therapy that we're delivering that we maybe not appreciating the impact of in terms of risk of death. And there's a great deal of variation in behavior across the nation. These are different buckets, lowest, average to highest in terms of prescribing opiates per capita. You can find your state here. Kentucky's way out on the far right, along with Tennessee, West Virginia, Oklahoma, and Alabama, in that we prescribe more opiates per capita than any other states. This is the people in the room. This isn't the patients. This is us prescribing opiates. We are guilty of creating this variability. So who's at risk? Well, people with overlapping prescriptions, they're definitely at risk. They get something from you, they get something from somebody else. That's not okay, we know. Taking high daily doses, going home taking 12 oxys a day or 20 oxys a day or something like that. People who have existing mental illness or substance use disorder are definitely at risk. And socioeconomics play a role. People with lower income are at higher risk of ending up in this situation than people in rural areas. That puts Kentucky right in the vortex. So how many pain pills do the patients really need? And can we limit the amount that we give them? What's the impact of just giving them less? There are two figures here. Both of these figures show the likelihood of taking pain pills at 1 year and 3 years after your initial prescription. The likelihood is on the y-axis. The figure on the left is the number of pills in the first prescription. The figure on the right is the number of refills. So let's take the figure on the left first. You can see that 1 year likelihood of taking in the solid line and 3 year likelihood of taking are both higher the more pills you give them. So if you want to decrease the chance that your patients are taking pills in a year, give them fewer tablets. And the figure on the right is refills. If you want to decrease the chances that they're still taking pills at 1 year and 3 years, don't give them refills, or at least minimize the refills. This is a very simple figure here that we should all take away. How many pain pills do they need? This is a study of patients undergoing upper extremity orthopedic surgery. 300 patients were surveyed. How many pills did you take? 50% of the patients said, I didn't take any, or I took one the first day, maybe the second day, first day. But that's it. They were done after the first 3 days, half the patients. And then the others sort of trailed off. This suggests that we're probably giving them more than we need to give them, that they're not having that much pain, at least for that long. So how are we going to manage this? How do we manage pain? I encourage you to think of this in a tiered approach, starting with the easy stuff. First is recognize the pain. Recognize it, acknowledge it, talk to the patients about it. It's relevant. It's not that pain's not relevant. First, remove the cause. Cool the burn is an example. Adjust the splint. Fix the traction that's uncomfortable for the patient, this sort of thing. Remove the cause if you can. Start with non-pharmacologic stuff, reassurance, changing positions, aromatherapy, music therapy, acupuncture, massage, all this would go in there, and we do all that at our place now. You can order massage. I can order massages and acupuncture for my patients, and the staff can go to a clinic. There's an outpatient clinic. They can get a discount massage. That's a side effect of having a massage therapy in your hospital. That's good. And then simple analgesics. I think this is the most important line for you to remember, this number 4, is that Tylenol works and NSAIDs work. They're probably more effective than opiates, and we underuse them. Now your adjuvants, the gabapentin, the skeletal muscle relaxants, maybe. Regional, if you're set up to do this, if you can get regional blocks, epidurals, tap blocks, all that stuff definitely helps. Now we're up to the weak opiates. Try tramadol first. Try that before you go to the heavy stuff. And then we're up to the heavy stuff, oxycodone, hydrocodone, fentanyl, of course, all that stuff. And then you're at a level where you're calling in your pain specialists to help you. Let me talk about opioid alternatives briefly. This illustrates the value of the Tylenol-Motrin combination. This is the number of people needed to treat for one person to be halfway better. I'm going to walk you through each of these scenarios. The far left is an Oxy 15. That's a big dose of Oxy, right? You'd think, wow, I'm really giving the patient something that's going to take care of their pain. You have to treat 4.5 patients with a 15 Oxy for one patient to be halfway better. It's pretty remarkable. It's really not the powerful painkiller that we think it is. The next one is Oxy 10, and you mix in some Tylenol. So less Oxy, but roll in some Tylenol. Now you have to treat only 2.7 patients for one patient to be halfway better. The next is an naproxen 500, and look at the most powerful regimen on this whole table is a simple 200 milligram ibuprofen and an extra strength Tylenol. 1.5 patients for one patient to be halfway better. That's definitely the preferred regimen here, and minimal risk. So your orthopedic traumatologist, your spine surgeons, they say, ooh, I'm worried about the NSAIDs. It'll keep my fractures from healing. I'll get fracture non-union. Is that a real thing? Well, we used to think it was, and the jury is still partway out on this, but let me show you a couple of encouraging pieces of data here on this. This is a systematic review looking at NSAIDs and fracture patients. There were 3 prospective randomized or good quality studies. There were 13 retrospective studies, total of 12,000 patients. This was their conclusion at the bottom, that there's no clinical recommendation that we can make regarding the appropriate use of NSAIDs in this context. We can't say they're safe. We certainly can't conclude that they're unsafe. They do say that a short perioperative exposure to NSAIDs is most likely not deleterious. Another recent paper, this is a retrospective study of a single surgeon's practice. He gave Toradol 4 times a day for 5 days, 20 tabs of Toradol. These were all malleolar fracture cases or malleolar operations. Single surgeon, 4-month follow-up. He had 2 blinded foot and ankle orthopedists look at all the films, 300 patients, no cases of non-union. Does it prove it? No, but does it suggest you're probably okay, at least with a short course of NSAIDs? Yeah, I think that's what that suggests. Alpha agonists, definitely these are an option for you. Easier to do in the ICU because they do cause some hemodynamic change. Clonidine would be appropriate in your ICU, out on the ward. It can be a pill. You can put it on as a patch. It's easy to give. The IV heavier form, right, could be Presidex. It's expensive, but it's certainly an option. You should know that these agents are opioid sparing. They should allow you to lower the amount of opioid that you need. Relatively easy dosing, Clonidine and Presidex. Special K, as it's called on the street. This is the future, I think. You're going to hear a lot about this in the next few years. The military's done this for a while. I know we're going to have a panel discussion. I'm interested in Dr. Eastridge's comments on this. Ketamine is definitely an option for you. People are starting to write a lot about it. Even things like ketamine infusions on the ward to minimize the amount of opioid required. It certainly reduces pain severity. It can be given continuously, intermittently, small, non-sedative doses, bigger doses for procedures. It has some abuse potential, but it's not relevant in the hospital. New guideline on sub-anesthetic infusion of ketamine. So this would be a continuous infusion in your ward patients. Can you do this? Yeah. It's a 0.35 milligram per kilogram bolus. Run them at 1 milligram per kilo per hour in your properly monitored ward patients. It can minimize the amount of opioid that those patients require. You're minimizing their opioid exposure, so you're less inclined to give them that huge prescription of stuff when they get discharged. And it's definitely should be an adjunct to your perioperative analgesia. Just avoid it in patients with cardiovascular disorders, cirrhosis, and who have known ICP. We used to fret a lot about it in ICP. Other options, muscle relaxants, benzos, gabapentin, antidepressants, antiepileptics. The jury's out on these things. Unproven is what I would say. Here's a paper from Denver that looked at rib fracture patients. Pretty decent dose of gabapentin, 300 TID. This is prospective randomized, but a tiny group of patients, really small, 20 patients. But they didn't see any difference. Numerical pain score, ICU length of stay, spirometry, quality of life. We give gabapentin like crazy. I don't know if it works or not. It doesn't seem to be harmful, so we give it. If you're into this topic, there's a great podcast on the East website. Babak Sarani is the gentleman shown in the left, and down the bottom right is Carrie Valdez. She's up in Michigan. And the gentleman in the upper right is an anesthetist. They have a great program at George Washington University where basically every trauma victim gets some kind of regional block. All the trauma labs get TAP blocks. All the ribs get epidurals almost always. And they do regional blocks for their fracture patients. It sounds fantastic. It requires a whole system to do, but they use very little opioids because they use all these regionals. So what works? Tylenol works for sure. You should be using more of it. NSAIDs work. Less opiates work. If you want to think about the whole system and the patients at risk and the opioid problem, less opiates. I think Nancy Reagan had it right. Just say no. Ketamine for sure. You're going to hear a lot about that. The ER doctors love this. Maybe we'll have some conversation about that in the question and answer. Alpha agonists for sure, clonidine. Regional blocks, if you've got that available to you. Lidocaine infusions, kind of new and cool, more complicated than ketamine probably. And then maybe this stuff at the bottom. This is great stuff. This stuff shows that you're trying hard and you care about the patients and you're listening to them. Do they work? I don't know, but they don't hurt. Massage never hurts. This is, last couple of slides here, this is what the Joint Commission says about opioids now. This number one right here, the hospital must have a leader or leadership team that's responsible for pain management and safe opioid prescribing. So you have to have somebody in your hospital that's responsible for this. And this is our guy at UK. This is Doug Euler. He's our drug czar, essentially. He's a PharmD. He's really devoted his job to pain control, but mostly reducing our use of opioids at UK. And here's an example of an order set that he created for us for our outpatient lap appies and lap choles. When my daughter had lap chole at UK, the chief resident gave her 25 Percocets or something ridiculous like this, and she didn't take any of them. I said, what are you doing? 25 Percocets, it's silly. It made it clear to me that we needed some sort of rails, some sort of guide for the residents, right? To like, here, this is what the reasonable amount would be. So we created this order set. You can see it starts with Tylenol. Everybody gets Tylenol. Some stool softener, great. Ibuprofen is the next. Then there's some oxycodone down there, but look, there are two options. There's a 1-day option and a 3-day option. So the 1-day option is 3 tabs. And then the 3-day option is like 10 or 12 tabs, that's it. And then tramadol's on there. So this has allowed us to get to a point where I give my lap appies 3. They get 3 oxycodones and that's it. Usually 3 tramadols, maybe the oxycodone. And this is what we've been able to achieve at UK, a 57% reduction in high-risk opioid regimens. Those are big doses, patients who take high MMEs or combining opiates with benzos. 1,300 fewer opioid prescriptions annually at discharge, and fewer pills dispensed. Remember, that directly relates to whether or not the patients are going to be taken at 1 year and 3 years. So we are the key. We're part of the cause, unfortunately. All of us in here are guilty, and I'm very guilty, but we're also part of the answer. Opiates are out. Multimodal is in, and there's definitely opportunity to study this. If anybody finds interest in this, lots of grant funding opportunities to study opiates and opiate reduction. Thanks very much for the invitation.